research interests. So he's going to give us an overview of mental health, especially in the global setting. Then I will already introduce the speaker who will also talk on mental health, who will follow Don. The next speaker is Dr. Norieta Balderrama. She's an associate professor at the College of Medicine of the University of the Philippines, Manila. She has years of experience in the practice of psychiatry. She is the head of the Wellness and Mental Health at the Child Protection Unit and works with Dr. Ramadrid. She's a past president of the Philippine Psychiatric Association and the Philippine Society for Child and Adolescent Psychiatry. She has worked with the DSWD and with other various local and international NGOs related to the mental health of children. She is the only expert in the country trained in forensic psychiatry from the University of London as a Chevening Scholar. She's a lecturer also at the Philippine Judicial Academy. So these two lectures will proceed, and we hope you don't mind that this is more of a working break. So habang consider it your parang luncheon, pre-luncheon symposium. So without further ado, please welcome Dr. Prisno. And after Dr. Prisno, it will be followed immediately by the presentation of Norieta Balderrama.
Thank you very much. I'm doing multitasking for this workshop, from being the final report writer and managing the whole workshop together with the partners. And I'm going to present before. So this will be a different presentation because we're trying to, in this presentation, we'll try to give the global perspective of doing research. So I'll bring you back to doing research from the case of looking at mental health among children and the youth. And then later on, it will be followed by Philippine data by Professor Balderrama. So we all know from the international laws that child health, mental health is very important. It's in the Rights of the Child international agreements that mental health is one of the main tenets of all these international agreements. In fact, some of the different lines that are being presented have to do with mental health, whether it's rest and play, not to be hurt, neglected, or used as a cheap worker or used as a soldier in war, and know about their rights and responsibilities, and so on and so forth. An adequate standard of living for mental, spiritual, moral, and social development. So everything is already agreed upon by the different states and different countries of the world. So what we are trying to look at is what are the different studies that would talk about mental health among children and the young. For example, there are many evidences that have been presented, particularly with the global burden of diseases. Interestingly, they can come up with all these evidences, and come to think of it, they come from national data. And then we question ourselves, where do they get this data? So when this data, for example, the global burden of disease, this is causes for females among children and the youth. If you will notice, mental health for females in Southeast Asia, it's not very clear. Self-harm will be one of the lowest. So if you go to, the pointer doesn't work with this system, it will be one of the lowest in terms of global burden of disease. Given the fact that it's one of the list, was there a good collection of data? So probably we also have to question this at the global level, if indeed mental health is one of the major issues. Why are these very important? It's because funding at the global level is influenced by all this data. As you all know, mental health in general is the least focused and the least funded. You will always know that HIV/AIDS, tuberculosis, respiratory infections, so on and so forth, there are billions of money being poured simply because the data would show that they are bigger in terms of burden. That's the reason why we question ourselves, what are the data that we feed to the global level? Maybe they should be higher. That's for the females. So it's for self-harm in Southeast Asia, it will be number 26. For males, self-harm goes higher within Southeast Asia, where the Philippines belongs. So that's the picture in terms of the global data that we have. However, there's also something that comes out, which is interpersonal violence among males in Southeast Asia, and it goes quite high within the global burden of disease compared to the females. So here in the Philippines, do we disaggregate this data when it comes to gender? So these are the things that we ask ourselves as researchers. The World Health Organization definitely focuses on child and adolescent mental health. Very specific, child and adolescent mental health. So which means it's affirmed that the global community thinks that there's a big problem in this. And one of the goals of the Department of Child and Adolescent Mental Health is to strengthen information systems, evidence, and research. So it's already enshrined in international agreements. Because we all know that worldwide, 10 to 20% of children and adolescents experience mental disorders. So that's quite high globally. And probably here in the Philippines, it would have similar indicators. And all mental health illnesses begin by the age of 14 and 3/4 by mid-20s. Neuropsychiatric conditions are the leading cause of disability in young people in all regions. Of course, why we need the data is because we want to influence policy and practice. It will influence funding. I will show you data on how funding is being done. One of the major outputs that we will be doing in this research forum will be publications at the global level, because we want to influence global health policy and practice. So we will be pushing you together with Consuelo Foundation and Access Health International that you will come up, hopefully, with very good research outputs published in preferably top journals of the world if we can. Because we want to create we have to make noise in terms of the data that will come out in terms of publications at the international level, if we can do that. So that we come up with journal articles, and of course this will be used as evidence, whether it's prevention or whether it's intervention among children, whether it will be violence or mental health. And even as far as the global level, mental health at their age is already being emphasized. There have been many studies at the international level on youth mental health. So they've been doing a lot of studies on the role of primary health care and so on. So we all know that it's a problem. I'm not going to emphasize on suicide, but now it's getting much worse in the Philippines. I think the next speaker will discuss this. Suicide is the third highest cause of death in young people. Specifically, it would include also depression, schizophrenia, and alcohol abuse. Poor mental health during adolescence and early childhood goes unrecognized, and their vulnerability increases because of poor psychological functioning in the immediate and long term. And of course, if we go, I think we have economists here, if we measure the impact cost of this, then that would be good, because we can show to policymakers that if we don't intervene and put money in the programs, then the cost to the society will be bigger. So as mentioned by the previous speakers, we have to go beyond just the community data. We have to extrapolate and discuss further from that data on how this impacts the bigger society in terms of cost. Access is a big problem, and health services for adolescents and youth who are at risk but who do not yet exhibit clinical symptoms are even more inadequate. In other words, as emphasized during the first discussion, Why do we focus on only on the marginalized and the most obvious? However, we don't focus on the gray areas, which actually would start to come out later on in life if we don't intervene. WHO wants to scale up services. Should we have all these services being integrated into community health programs? I think there have been a consensus that it would be best if we integrate these services in a mental health program. But then we still have the questions of whether we have to have vertical programs in terms of mental health, then they will compete with the budget, or we incorporate them with the barangay health workers as part of their work. So these are the questions in terms of health systems and health programs. Primary care mental health services facilitate the early identification of treatment. That's why we say Cuba has a very good health system, because they are very strong at the community level. Well, it is true, but is it best for us here in the Philippines? Because in Cuba, at the community level, it's already a complete holistic service, wherein at the community level, they have primary healthcare workers, doctors, including pediatricians. It's like a barangay health office, and they go house to house within their captive community, the whole country. So that's why at the very early onset of any disease, they can already capture. But do we have the resources for this? So, and again, their health workers are all state employed. And we have a very mixed health systems here in the Philippines, where the private sector is very, very powerful. Can you pay them 10 camotes every month? Will they agree to that? Of course not. Dr. Mantaring, who's a neonatologist, you know, everyone have their own turf, and it's very difficult with a mixed system. So it was a bit not so good for the government to say, go to Cuba and examine it, because it's actually already written. They have the perfect outcomes, but maybe the means to go to those outcomes may not be the best. So we have to reflect on this also. And we're just talking here of adolescent, youth, mental health. How much more with the other issues that we are facing? Cross-cutting themes in this research, researchers and decision makers must adopt a life course approach. This is one issue that we have here in the Philippines, because we are doing things in silos. We don't look at the life course of the child from the time the child is born until he or she becomes an adult. So there are only a few studies which try to look at a lifespan. I think there's one in Cebu, and there's another one. But we don't have these big studies where we look at a cohort of, let's say, 100,000 children born. And then we look at them across time, 10 years, like a Framingham study. So are we ready for this as researchers? Like a 30-year study looking at 100,000 children. These are already being done in other countries. Remember, we have a big population, and that is very important that we get elevated to all this form of studies. Thus, we create evidence-based programs. That's eventually what we have to, and of course, context matters. So it's not very clear. So these are some of the examples of selected findings on mental health, disorder prevention, mental health programs. And these are very specific methods and the research gaps. So probably one of the things we will come up with in the report, we'll look at what's happening, the main findings on some of the researches presented, and the research gaps that we will be identifying as part of the output of this workshop. It's not very clear. So this one is on child abuse prevention. So they collated different studies. So everything that has been said here, we will map them out and then come up with the main findings and research gaps. This is on child abuse prevention. This is on early childhood education. Unfortunately, we couldn't get speakers from school health, but we have participants from school health. Remember, a big part of our children, they go to school, yet they are not here. Even DepEd is not here. And they are the ones facing the children every day in 1 year. It was our fault. We couldn't get a speaker from, they're having Christmas parties now. You know, there's a big section in DepEd on child health and nutrition. So this is going through a life course approach, and then we can look at the main findings and research gaps. Mental health promotion interventions. What have been said here in these discussions? There was a good presentation prior to this. We will look at the main findings. As researchers, we have to understand what are the different measures that we're going to measure. What are the indicators? I have been listening from the very start. Many of you have been discussing process indicators. How many participated? How many participants were there? Where do they come from? But we don't measure really the long-term outputs as mentioned by one of the researchers here. So what are the output measures? And then main findings and research gaps in terms of mental health promotion. School-based mental health interventions, do we have those? And we have a lot of children in this country. We're now 110 million people. And we are going to reach, soon in a few decades, 150 million, 200 million. Thus, as early as now, we have now to prepare the baseline for all of these things that we are being faced with. Because if we keep on waiting, when we reach 200 million, then we have bigger problems as a country. So it's better that we start now. And look at us. We're just few among 110 million population. Where are the researchers? Where are the universities? Early interventions for psychosis, you come up with all these interventions. Even omega-3 fatty acids. I didn't know that it was, it is. We have many pediatricians here. Building research capacity in mental health for children requires a skilled, global, collaborative, multidisciplinary research workforce. That's what we are doing now. And of course, you, my dear friends, will be competing with the other research themes, research areas. After this, if you get invited to a TB program, research program, you will move there. Then if you get invited to another research area, some of you will do that. So we also compete within different research areas. Same with our office. We do a lot of different research themes. We should develop and sustain a global cadre of researchers, and that requires several interacting factors to be considered. Countries must provide training and capacity building, and this is just from a mental health for children global article, and they are already emphasizing on this. So this very good Consuelo Foundation has started this. Luckily, we have them as our partner. In low and middle income countries, there's limited mental health research activity, and as do the lack of graduate programs and the pressing need for clinical service providers. So you have the cycle that was presented by Dr. Mantaring. So we have all the data. The data is just there, lying around. As a researcher, we have to look at them and analyze them. Even if they are anecdotes, as long as they are systematically analyzed, they are. Qualitative research is data. But again, what would matter is how you look at the data, how you analyze it in a rigorous manner. That's why you take masters and PhD. You go to different schools. So in terms of funding, there's not much funding on mental health for children and adolescents. Unfortunately, probably because there's not much data on this. So we are really less. We are green in these areas. Some are much worse. So luckily we have partners. And mind you, there are big funding for adolescent health. There was like an £8 million call globally for research on adolescent health. But if you don't have a good proposal, that is another skill as a researcher that we have to have, then you call us Access Health International. Because we will work with you to come up with a proposal. Because we're a think tank, and that's what we do. That's what we do in our work. So you see, because we don't have the evidence, then we compete with the other big problems of the world. So as you will notice, global child and adolescent mental health funding, it's actually an orphan health research theme. So it goes up and down, and most of them these are the different sources of funding, and most of them will come from humanitarian aid. Have you noticed in the Philippines, most of our researches are because of disaster, mental health. Oh, there's Haiyan. We have all the psychologists on television. Oh, there's earthquake. We have all the funding that's being poured. So when there's a disaster, that's only when mental health among children comes out, right? And then we are being questioned, why do you only focus on this? At least there's something that pushes the funding. But what about the school children, which is just millions and millions of them? We don't focus on them because we don't see it as a priority. So again, funding goes up and down, and it still is an orphan in terms of area of research. So as I mentioned, UNICEF, who's not here with us right now, they are the ones who keep on coming out with all these studies. And I think they have a way of collecting data. So this from their report that disasters and conflicts, because this is where the funding is. That's why we will have a lot of studies in Marawi among children, mental health, because that's what, so we have projects with the World Bank, and they love that area. So expect many studies, but not in other areas. So they will come up with natural disasters, climate change, and conflict. That is in their annual report, focusing on mental health, but not other issues. But come to think of it, there's a question on this, why focus on them? We indeed have to focus on them because of the concept of equity. So we focus more on those who are not being discussed. Unfortunately, the focus is highly emphasized that a big part of the money would go to them. So that's why we need all the evidences for the other areas of research. So high rates of violence against children, luckily we're moving this forward. And these are so when you come up with data, you have this infographics. We call this dashboard in other areas so that you can see in an overview that is easy for the population to grasp the data. So as researchers, we also have to be good communicators. So having this, for example, this data from the Philippines, 2 in 3 experience physical violence, 2 in 5 experience psychological violence. And that's actually, if you are epidemiologists here or quantitative researchers, if you extrapolate that in the bigger population, that's actually a lot. But then again, if it becomes bigger, you will be questioned, where did you get your data? So if you will notice also with the other diseases, such as HIV/AIDS, TB, why do they have very good data? We can count the estimates of the number of HIV/AIDS every year, because they have sentinel sites and so on. Same with the other reportable diseases. Why don't we have it in this field? So that's why they can come up with quick reports at the end of the year. And there are estimation activities. That's why we can come up with HIV/AIDS every year. You know what they do? We discuss denominators. We look at denominators in the country. For example, what's the incidence of HIV/AIDS among men having sex with men? You know what's the denominator? Men having sex with men. How do you count them? You don't come up with a national survey and asking, either you do sampling or you come up with, gather all the experts and they actually vote. On like, let's estimate the number of gay population and the non-gay but having sex with men. So we come up with a denominator, we come up with the population of boys and men, and then we come up with the percentage. You have some indicators from every section of the country. You do some mathematical extrapolation, so on, and then you come up with the national data. So even if we don't have the data, UNICEF can come up with it because of these methods. So this is where you come in as methodologists. So it's not only about, there are many ways of doing all this data gathering. So we can come up with the national figures. That's why there are global figures. Then you question yourselves, where did they get it? Because of these various methods. So these are some of the findings. I think this will be emphasized in the next presentation. Sociocultural norms, practices, and beliefs. Corporal punishment, this has been mentioned. Subordinate position to men, this is the gender dimension. This came from the report of UNICEF. So again, we go through different dissection of this already. It has been mentioned yesterday and today. And the big agencies would come up with all this collation of data. Social religious norms that render sexual activity among young and married people unacceptable have suppressed demand for family planning services. So beyond the data, we look at the policy implications. Why are our family planning services not being visited by adolescents? Because they are denied access, for example. So there are always policy implications of what. That is the reason why you have to translate your findings into come up with a gathering that you will have all the policymakers there. Stigma is still there. With violence, in particular, sexual violence has resulted in underreporting and limited demand for justice and social services. Boys' access to education and their educational attainment is actually a gender.
March 2019 was done by Cristal Estrada, where I reviewed as a panel, reviewing the thesis. And her study showed that non-specific suicidal thoughts, active suicidal thoughts is about 40% among adolescents attending the alternative learning school. So that's big, very high. And those who attempted was about 16%. So I think that is the issue that when you talk about mental health, that is afflicting our country right now. So this is only the study on the alternative learning system adolescents. So today, we will have to also consider when discussing the mental health in the country, look at the different areas which we have been discussing since yesterday regarding, of course, psychosocial issues, disaster, you have malnutrition, poverty, poor education, politics and other factors, and mga cynical or not, there are a lot of factors. And also to top it is, if you go to court, because that's also my practice, no one wants to touch children who will have legal problems. So there is a slight indication that they have legal problems. No one will touch the child either for therapy, for treatment, because of fear of going to courts. So that is, I think, a reality that we have to address as well. Because in the scheme of things, the intervention and the legal system has to blend, not separate the legal intervention from just the other psychosocial interventions. So we'll be here until this afternoon. I have 100 slides. I hope to be 15 minutes. So we'll just discuss common from my end, the ones that I am exposed with. So what I did was look at the data of the Philippine Psych Association. We do have a journal, and also our department. So we have 3 training institutions. So aside from PGH, for child psychiatry, we also have PCMC, and then the latest is Medical City. And then just review some of the research materials in a nutshell. And lastly, some of the interventions that we've been doing at the Child Protection Unit. So it's very important, I think, that we are up to date because of the Philippine passing of the Philippine Mental Health Law. I think you're aware that it was passed this January, the IRR, at the National Center for Mental Health. So what does it say? So when you talk about children, you look at the area where you look at the mental health of children in the school system. So all schools now are required, aside from hospitals, district hospitals, to actually come up with mental health programs. So I'm sure if schools are aware that they have to come up with a mental health program by law. So basically, because this is also what I discussed with psychiatrists, is the effect of the mental health law on the school system, because they should provide programs in the school setting. But if you look at the reality, if you have programs and if you have problems, you look at the services. So there are very few child psychiatrists in the Philippines, so more than 100 million, 110 na, no? And you only have how many psychiatrists, child psychiatrists? Only 70, no? So, including the ones who are going to graduate, probably about 78, no, of us in the Philippines. And maybe yung mga child psychologists, maybe roughly the same, no? Kasi parang the trend is we started with 10, 15, and then going up. And then you have the developmental pediatrician, about 100 of them also, who can take care of this. So basically, if you look at the population, we have under 14 years old, 37% of the entire population. So we really have to do something about the services. And 6 hospitals, if you're suicidal and you don't have money, you are actually staying with the adults. So there are only about 4 public general hospitals with psychiatric wards, and 46 only, very few, outpatient facilities, and only 2 specialists, no, per 100,000 individuals. So I think that's a big gap that we have to deal with, and that there are only, as we've said, 2 beds for children and adolescents in 2 psychiatric hospitals. Imagine the whole of the Philippines. That is the data that we have. So if you get sick, where are you going? Either in the public, but if you don't have money, you have to be with the other adult patients. So it can really be very difficult. So that's why these are the issues that we have. So you have, of course, number 1 will be depression and suicide. And when you talk about depression and suicide, you also talk about the other disorders. So when you say depression, it can be bipolar, it can be major depressive disorder, or the DSM-DD, which looks like bipolar, which is also increasing. So the DSM-DD, we also have to take a look at this. So at this point, it is also very important to note that a group, this is the group of Dr. De Guzman, who's in charge of coming up with the prevalence of mental illness in the country. So hopefully it's going to be done by 2021. So this is for adults, and we're helping her with the child prevalence. So it is now a whole discussion of how many hours our children now spend with their gadgets, right? And